All right, we'll get started. Welcome to this next webinar from the Corticare webinar educational series. Today's topic is Insula, the lesser known fifth lobe. And the content, I can guarantee you, is very interesting and very timely. The presenter tonight again is Dr. Navita Kaushal. And if you've not seen some of the previous webinars that she's presented, I'll bring you up to speed. She is currently LTM manager and continuing education coordinator for Corticare. But previously, she was a EEG technologist at Einstein Medical Center in Philadelphia, and she was an adjunct faculty member at Delaware Community College. From 2009 to 2012, she was a research professional associate in the Department of Pediatrics at the University of Chicago Medical Center. She received her BS and MS from Punjabi University in how do you say that? Patiala, India, and her PhD in physiology from All India Institute of Medical Sciences in New Delhi. I want to welcome her, and I want to welcome all of you to this presentation, and I will just give you these additional notes. This is being recorded, and the recording will be available in a couple of days. You'll get an email when that is available, so you can rewatch the webinar itself. At the end of this webinar, about an hour later, you'll get an email with a link to an evaluation form. If you are attending for asset CEUs, then you do need to complete and submit that form, and then we'll turn that into asset so that it's registered. Without any further ado, I'm going to hand this off to Dr. Kaushal.
Good evening, everyone. Thanks, Jeff. So if you were there prior to this webinar, we had talked about frontal lobe epilepsy, temporal lobe epilepsy, and we're going to talk about insula. Since grad school, we have been talking about the four lobes, right? Just the four lobes, the anatomy of the brain, four lobes, that's what we are talking about. But from 2000 onwards, insula, the hidden lobe, the fifth lobe, insula literally means an island. So it's picking up interest, picking up global attention when it comes to its anatomy or its functions and its role in different types of epilepsies. So this presentation is based on review of literature, and I did not contribute to any of the research articles which I'm citing here in my presentation. The relevant publications that I used to prepare this presentation are provided at the end. And I did give this talk during ASSET under a different title. So when I did this PubMed search back before when I was presenting for ASSET, as you can see, insula and epilepsy. So if you do that search in PubMed, you see there was hardly any research done in 1950s and 60s. However, it did pick up some interest of some of the big shots like Bannicoot, Penfield, and some other known names that we still use in our epilepsy studies. And then there was a lull. Hardly anybody was talking about insula. And then in year 2000, it did pick up global attention. And by 2020, 2023, there are about 80 to 90 articles published in PubMed on insula and epilepsy. So where is this fifth lobe located? Now, this is the only part of the brain, only cortical part of the brain, which is not visible. It is covered by frontal, parietal, and the temporal lobe. So that where these three lobes meet, we call that opercula. Opercula literally translates to a curtain. So basically 3 curtains from 3 different lobes is covering insula, and it is situated right beneath where these 3 lobes meet on the lateral aspect of the hemisphere. Insula is divided into 2 parts. It has its own cortex, it has its own sulcus, which divides it into anterior and posterior. So a total of 5 gyri, 3 in the anterior part, 2 in the posterior part. And it is an eloquent cortex, and it is supplied by M2 segment of the middle cerebral artery. So it's a highly vascular structure. Here is a location. So when you lift the curtain of the frontal, parietal, and the temporal lobe, you see an island. And like I said, there are 3 gyri in the anterior and 2 in the posterior. So your insula is divided into 2 parts. There's beautiful anatomical picture is taken from Ken Hub. Please visit that website. I have no connection to that website, just to say. It has great images of anatomy of the brain. Now, it's not just that we are talking about these 3 lobes, right? The core, the center of the brain, okay, the hippocampus, the thalamus. So all those areas are also, they are connected to insula. So the inner surface of insula here is connected to the central core of the brain. What are the functions? Now, if this part is covered by 3 lobes, chances are that it is going to share some of the functions of those 3 lobes, right? So insula is involved in a number of modalities like pain, taste, smell, hearing, balance, autonomic functions, cognitive behavior, emotional experiences, self-awareness. There are more studies which shows that the connection between amygdala and insula is also responsible for fear response, how we react to a given situation and things like that. Insula is highly connected, not just to 3 lobes, but to the central areas of the brain too. So there are projections going back and forth from the frontal, temporal, and parietal lobe to insula, and from insula to these three lobes. And of course, the limbic system and the basal ganglia, they also share afferent and efferent projections with insula. So let's look at what these projections are actually doing. So there is an overlap of functions, there's an overlap of seizure semiology and things like that. So we just covered the functions of insula involved in pain, taste, smell, hearing, autonomic activity, emotions, self-awareness. Now its projections to and from temporal lobe. Temporal lobe is responsible for understanding language, memory dysfunction, face and object recognition, perception, and processing of auditory information. So having the projections from temporal lobe to insula and from insula to temporal lobe, so you can see some of these functions are shared pretty decently. Same thing is frontal lobe. The motor skills, language, emotions, and executive functions of the frontal lobe. And if you look at the insular functions, emotions, self-awareness, cognition. So these projections back and forth are responsible for certain characteristics. Parietal lobe, processing and interpreting somatosensory input. And insula is also responsible for some of the somatosensory functions in the body. The limbic system. So hypothalamus, amygdala, and thalamus, and hippocampus, of course, they constitute the limbic system. They are responsible for emotional responses, basic survival behaviors, fight and flight response. And if you look at the functions of insula, you see the autonomic activity. So some of the autonomic functions, emotions, they're all taken care from the insula. Then comes the olfactory. So the projections from insula travel to the olfactory bulb. So the smell, the social cues, and all these are associated with emotions and self-awareness. So this is a one-way projection from insula to the olfactory lobe. Then comes basal ganglia, which is responsible for motor control. Some of the studies show that removal of insular cortex led to hemiparesis and some sort of motor deficits. So basal ganglia is involved in motor control, behaviors, and emotions, and it sends projections towards insula. And if you can see, these functions sort of overlap. little history of insula and its associated functions and its role in epilepsy. So in early 1800s, anatomist J.C. Rale was the one who described insula. And this part of the brain was known as Rale's Island or Rale's Insula. Gradually, his name kind of disappeared and we just got stuck with the term insula. As more and more anatomical advancements were made in the medical sciences, detailed characteristics of insula started to emerge. Penfield, it mapped it first time in 1950s, the electrical stimulation of the brain. So he is a father figure in electrical stimulation, right? So he functionally mapped the insula, brought out its different functions and their overlap with the temporal lobe and the frontal lobe. And at that time, these neurosurgeons, anatomists, they started to talk about its role in epilepsy of different lobes. So they thought there is an overlap and insula may be an epileptogenic zone for certain epilepsies, because of the seizure semiology being so similar. However, in another 10, 15 years, there were some papers published which say that the benefit is very low, the risk is very high. At the same time, Penfield, who brought up the idea of insula being such a big deal in overlap of epilepsy functions and semiology and things like that, right? He also published a paper which says that risks are more than the benefits. People are not getting benefit. They are not becoming seizure-free after part of insula is removed. And hemiparesis, morbidity, it kind of increased in people who underwent insular resection. So that kind of created a conflict in the epilepsy world, and people stopped talking about insula. And it went into sort of a dormancy. Nobody's talking about it. Nobody's doing anything. People are still talking about 4 different lobes of the brain and the epilepsies which are originating from these 4 lobes. In 1980s and 90s, when the brain imaging, it's kind of picking up, there are new techniques coming up, and its role in diagnosing different epilepsies and figuring out the lesions, their association with the clinical features of epilepsies and things like that, they started to talk about insula again. And they started to do deep brain stimulation, deep brain recordings. The very first seizure from insula was recorded in 2000. And that's when insular epilepsy and its role in various seizures, onset of seizures, and people not getting better after resection, it kind of picked up from there. And if you remember the chart I showed you after 2000, there is like no going back. There are about 90 publications just in the last year on insula. So before we dwell into the seizure semiology of insular lobe, let's talk about the seizure signs and symptoms from the other lobes. Frontal lobe, motor manifestation. So huge motor movements, right? Posturing, bicycling, negative phenomena like motor and speech arrest, vocalization. The only aura in frontal lobe is olfactory aura. Patients are thrashing and kicking, so these could be preictal or ictal signs. Then come the parietal lobe, which is mostly somatosensory. Patients complain diffuse of local pain, paresthesia, interabdominal sinking, nausea, vomiting, sensation of choking, like as if they're underwater, loss of spatial orientation, and disorientation of the body position. The temporal lobe. So 70% of the patients diagnosed with seizures and epilepsies have temporal lobe epilepsy. During this, there are motor manifestations, but they're not as big as they are in the frontal lobe. They do have automatism, behavioral arrest, steering. Consciousness is impaired. Auras and hallucinations, autonomic symptoms, some sort of psychic aura. nausea, belching, epigastric sensation, respiratory arrest, sense of fear and panic, sense of doom. And look at this. So insular seizures are sharing semiology with all three lobes. And that is quite a fitting scenario, right? All three lobes are meeting right on top of this island. And there are projections back and forth from insula to these three lobes. So what are the chances that we are talking about temporal lobe epilepsy, but it is actually insular lobe epilepsy, or same is the case with frontal and parietal. We talk about secondary generalized seizures. They start in one part of the brain and then they generalizes. So are they originating from frontal lobe and then they travel to insula, and from there, because of its vast projections towards temporal and parietal, it kind of spreads to the entire brain. So that is still to be proven. That is, I wouldn't say proven, that is still need to be an acceptable thing, still have to come out as a big deal in the epilepsy world. So here is a list of signs of insular and insulo-opercular seizures. So seizures that are originating right in the insular cortex and originating where these three lobes meet with insula. And like we just saw before, this semiology, it kind of overlaps with the frontal, temporal, and the parietal lobe. I'm not going to read through it, but these are the similar semiology that insular lobe seizures and insular opercular seizures share with the other three lobes. Patient is conscious. The seizures originating from insula or insulo-opercular region, they are the focal aware seizures. We used to call them simple partial seizures once upon a time. How do these seizures evolve clinically? What are the clinical signs? Patient is very much aware. They think that they are kind of drowning, they are underwater, they cannot breathe, so they complain of laryngeal constriction. They have paresthesia of larger areas. It's not that an paresthesia in the hand or fingers, it's larger areas. It can be torso, it can be shoulders, arms, or legs. And after that, it kind of leads to some sort of auditory hallucinations, or they may have speech impairment. And this can go as further as a hyperkinetic function also, like the focal dystonic posturing. What do the EEG look like? Well, we cannot record from insula. Our 1020 or 1010 cannot record from insula because it is deeply situated. So the interictal discharges, they are seen over frontotemporal, frontopolar, or mid-temporal. So parietal, not so much, but the interictal discharges are seen in the frontal and the temporal channels. So this publication here, which talk about insular opercular seizures manifestation with sleep-related paroxysmal motor behaviors. So here, in this paper, they collected data from their center, the patients who got, they came for epilepsy surgery evaluation. And from I think 1994 to 2010, these 14 years of data they had from these patients, and out of that, only 8 patients qualified to be in this study. So what was the qualification criteria? Some lesion, cortical dysplasia of the insular cortex or in the insula, some sort of opercular onset of seizures. So these patients underwent deep electrode recording, the intracranial EEG. One of the patients had hyperkinetic complex motor behaviors. This motor behavior is usually seen in the nocturnal frontal lobe epilepsy. It can easily pass as frontal lobe epilepsy. So if you see here, hyperkinetic automatism, dystonic posturing, patient have aggression and violent behavior during sleep or when they wake up from sleep. What did the EEG look like? So when the patient is awake, so this is intracranial EEG. When the patient is awake, there are some interictal discharges at at the frontal polar region, at the insular gyrus, and some of the temporal areas. During the non-REM sleep, the interictal discharges increase in voltage with some faster frequencies. And the seizure is in the frontal lobe and frontal polar and in the temporal areas. There is some evolution in the insular region too. So with this study, if it wasn't recorded from the insular cortex, right? So the seizures look like they are coming from the frontal polar or from T1 and T2 area. So the epileptogenic zone in this particular patient happens to be insular cortex. And from there, the seizures spread to the frontal polar and the lateral temporal, superior temporal and middle temporal gyri. Now, keeping that thing in mind, the EEG that we saw, like let's say the patient got diagnosed with temporal lobe epilepsy based on, they did not study Insular, right? They did not record from Insular. And it's just temporal lobe epilepsy. From last so many years, before 2000, we are all talking about temporal lobe epilepsy, frontal lobe epilepsy. Nobody's talking about insular epilepsy. And how many of these patients undergo temporal resection and they come back with between 2 to 10 years, and they have they have seizures, which are originating again from temporal lobe. So it means the resection did not help them, did not resolve their seizures. What could the reason be? The reason one is there is an insufficient resection of the temporal structures. So temporal is, if it is a left side one, it is an eloquent cortex, right? The language is right there. So they have to resect so that patient does not have deficits after the surgery. There could be dual pathology. That means there is coexistence of mesial temporal sclerosis and extra hippocampal lesions. There could be a relapse. So they resected one side of the temporal lobe which was the epileptogenic zone, where the seizures were coming out. But then after that area was resected, the patient developed seizures from the contralateral side. Now, it could be extratemporal or temporal plus epilepsy. So almost 20% of the cases, they fail because of that. So you have pseudotemporal epilepsy. Could be temporal plus epilepsy where the epileptogenic zone extends all the way to the insular cortex. Nonetheless, almost 30-40% of temporal lobe surgeries, they fail in seizure resolution. So going back to the anatomy here, so if you look at this insula, it has similar ictal signs and discharges, okay, to that of temporal lobe. So 10 to 15% of the temporal lobe seizures are actually originating from insula. And the seizure which originate in temporal lobe, they are always invading insula because of the close proximity, very thick projections back and forth between insula and temporal lobe. So this kind of is a recipe of failure of temporal lobe surgery. And this started to gain attention in 2000 once they recorded seizure right from insula. So how do they diagnose? What is the diagnosis for the insular epilepsy? Well, scalp EEG is of no use because you are going to see the discharges originating from elsewhere. MRI is one of the very useful techniques. SPECT and PET are not as specific, so they did not reveal significant changes. MEG can be useful, but the most useful thing after MRI is intracranial recording from the insula. Now we have already said that there is difficulty in diagnosing epilepsy originating from insula due to its deeper location and its unusual seizure semiology, which are shared by other three lobes. With the modern neurosurgical techniques, forget about in 1960s what Penfield came up, right? So Now the techniques are much better. They are less non-invasive. So insular epilepsy surgery is both safe and beneficial. But keep in mind, there is no such resection of only insula. If the patient has epileptogenic zone in insula, it is not just the insular resection. Insula is resected along with part of the temporal lobe because of the projections. So insula is an eloquent cortex. It's highly vascular, supplied by the middle cerebral artery. The injury to insula can lead to hemiparesis and dysphagia. There is a 50% success with minimally invasive surgical options like laser interstitial thermal therapy, radiofrequency thermocoagulation. However, gamma knife and RNS, they are rarely used for insular epilepsies. 70% success rate is in the insulo-opercular cortectomies. So since it is an eloquent cortex, they cannot resect the area, so they are going to sort of minimize the synapses, minimize the projections and connections between the insula and the operculi. And that surgery is one of the most successful surgery to resolve insular seizures. Let's go over a couple of case studies. The first study is insular epilepsy, a great mimicker. So a 58-year-old overweight man, he's presented with a drowning sensation, complains about oropharyngeal constriction, nausea. He has some alteration in the consciousness, and he reports disorientation. He did get diagnosed with sleep apnea. Pulmonary function test was done, scalp EEG was done, the sleep studies, they were all normal. Then the intracranial EEG was done. It was normal. Brain MRI shows hyperintensity in the right insular region. So based on that, he is waiting for resection, and he's on Keppra and is symptom-free. The second case study is insular stimulation produces mental clarity and bliss. Insula is not directly related to ecstatic epilepsy, but stimulation of insula does produce mental clarity. So in this case study here, patient with refractory epilepsy since age 1, patient does have a left hippocampal sclerosis, and his symptoms are thoracic oppression, impairment of awareness, automatism of the mouth, bilateral hypermotor signs. He does not have any ecstatic symptoms. The cortical stimulation was done to rule out any extratemporal epileptogenic zones. So with the stimulation, it did produce a blissful sensation in this patient. So he found mental clarity. There were no discharges in the IEG. These are the patient's own words. Everything seems simplified. He could take care of multiple problems at the same time. He felt liberated. He had strong feeling of fullness. Consciousness has suddenly enlarged. It's like looking at infinity. I no longer have any limits. So what does it show? It shows insula goes above and beyond whatever function we were just talking about. So anterior insular cortex is a modulator of higher cognitive functions. Considering its close proximity to the frontal lobe, which is a site for cognitive and executive functions, and with the thick projections back and forth, anterior insular cortex plays a big role in the cognitive functions. This patient underwent surgical removal of part of his brain, and he is seizure-free. So when this paper was published, I think they followed the patient for a couple of years, and there were no reports of seizures on this patient. Another case study. Insular epilepsy with non-localizing scalp EEG, and interesting semiology. So here, it's a 53-year-old right-handed man who developed seizures at age 16. His symptoms are bilateral facial tingling, hyperkinetic movements, which lasted for almost a minute. He does have retained awareness, but he returns to his baseline. Now, when you look at these symptoms, they kind of look like hyperkinetic movements. It looks like a frontal lobe epilepsy, right? Frontal lobe seizures. He has 1 to 3 seizures per day. He underwent right anterior insular resection without any complications. And over 2 years post-op, he does remain seizure-free, and he's on medication. This is the EEG on this very patient. The top image is scalp EEG. His clinical signs originate at the red marker here. If you look at that, there is no significant change in background, but due to its hyperkinetic movements, we have lots of EEG artifact. Now, the SEEG is a different story altogether. So here, the red arrow shows the beginning of a seizure here. And these are the electrodes which are placed in the insula. So the patient has right anterior insular seizures. After the resection, the patient was seizure-free. The third case study is from a review article titled Temporal Lobe Epilepsy Surgery Failures. It's the case studies of a 52-year-old man with medical refractory epilepsy since age 20. So here, patient does show abnormality, and there are temporal seizures. And with the EEG, with the intracranial EEG, there are seizures that are originating from the anterior insula, from the temporal lobe, and the resection of the part of insula along with the temporal had the patient seizure-free after the surgery. So what are the outcomes of insular epilepsy surgery? This publication that I used to present the slide, there are 19 studies with 204 cases, which has almost similar number of pediatric as well as adult patients. The median age is 23 years, 48 men and 52 women. There are 43% of the cases had neurological deficits, where in that only 10% were permanent. 21% of these patients, they report extremity paresis, facial paresis in 19% of the patient. When the surgery was done on the left side, the language deficit is about in 24% of the patients. However, more than 70% of these patients, they remain seizure-free with a 1-year follow-up. So yes, there are some deficits that happen after the insular resection. SUDEP. So many cases, especially in neonates, especially in pediatric population, even in adults also. What happens during SUDEP? It's basically respiratory depression, and patient has cardiac arrhythmias, and some patients, it's not the seizure per se, right? What happens during the seizure. So they get into cardiac arrest. Now, going back to the functions of insula, does insula has anything to do with SUDEP? Insula regulates your autonomic functions. Respiration and cardiac rhythms is one of those autonomic functions. The electrical stimulation studies are done on insula. It shows the patient develop apneas, and when the left insula is stimulated, it causes bradycardia and decrease in blood pressure. And stimulation of right insula causes tachycardia and increase in pressure. So if you put 1 and 1 together, so how much role insula is playing in causing SUDEP during a seizure? psychopaths and empaths. What does insula do in these people? So insula is there for cognitive functions. It has connections with amygdala. Amygdala is your fear response. So people, psychopaths, they do not have similar kind of fear response, right? So they have low gray matter density in the orbitofrontal cortex and the anterior insula. Study done on incarcerated homicide offenders also shows reduced gray matter volumes in the temporal lobes, hippocampus, and insula. So hypoactivity of the insular cortex it could be a marker of psychopathy. There is a disconnect between amygdala and insula. Like amygdala is your fear response. So if there is no sense of fear, right? No sense of fear. The decision making is totally different. That's why we are talking about psychopaths. We're talking about incarcerated offenders. So there is a disconnect between amygdala and insula, which can lead to certain behavioral characteristics. However, on the empaths, on the other side, insula is hyperactive. So these are two amazing studies done on people, psychopaths and on offenders, and role of insula. So these are most of the references are here. Feel free to read them, and I'll take any questions if you have.
And the best thing to do now is to enter in your questions into the chat area, and then we can take those. So if you go right over to chat and put those in, I will be sharing those with the group. So we'll give you a moment to do so. There is a question just asking you to explain SUDEP, if you could do so.
So during SUDEP, there is a suppression of respiration. So if the seizure is prolonged for a longer period of time, suppression of respiratory, like it's sort of a respiratory arrest, and increase in heart rate can lead to cardiac arrest, and which is going to decrease the blood flow and ultimately stop the blood flow to the brain. It can be fatal.
And SUDEP itself, the acronym stands for sudden unexpected death of epilepsy. Is that correct?
Yes.
Okay. And then if you could just expound a little bit more on stereotactic EEG and its function in assessing for surgery for patients that may have insular-related seizures.
So to qualify for epilepsy surgery, the patients have to go through a relay of tests. We start with the 10-20, then 10-10. Once it is all defined that where the seizures are coming from, are they coming from certain lobe or none of the lobes are showing any signs? So based on clinical semiology, it has been assigned that, okay, the seizure is coming from this particular part of the central core of the brain. The patient undergo either the cortical EEG or depth electrodes. And once the seizures are recorded, okay, so and these electrodes are placed on both sides. If the depth electrodes are placed in one hippocampus, it will be placed in another hippocampus, because depending on it may not be the seizure is originating on one side, but the semiology is shown on the other side. And if the seizure kind of travels from one part to another, so that's why bilaterally depth electrodes are placed, and the patient undergo intracranial EEG. And when the seizure is recorded, it is marked, and now they know that, okay, this is where the seizure is coming. What part of the brain it is coming from? Is it part of the eloquent cortex? Is it safe to remove? Then the patient undergo brain mapping and things like that before they even go for epilepsy surgery.
Nice explanation. By the way, is there any content in this that would be specific for the CLTM credential exam?
So it's basically seizure semiology. The seizure semiology of different lobes. I don't know how much CLTM is talking about insular epilepsy, but at least temporal, parietal, and frontal lobe epilepsy seizure semiology is definitely part of the CLTM exam.
This class of seizures, are they more related to genetic disorders or more related to, traumatic brain injury or?
Some of the epilepsy, some of the insular epilepsy is due to cortical dysplasia or lesions or maybe trauma to the brain. There is not many studies which project towards genetic insular epilepsies. Like I said, there was a lull period. Nobody talked about insular epilepsies. Nobody talked about correlation of insula with the other lobes. So from 2000, we are talking about insula and its role in epilepsy and how the semiologies overlapped. I'm sure more and more studies will be performed to define, is it genetic? Is it just some sort of an anatomical anomaly which is causing these seizures?
And again, maybe you can speak to it or not, but it appears that a lot of patients that have this condition would benefit primarily from surgery, but are there specific medications that have been effective?
I think just the general medication that they give for focal seizures or for generalized seizures. And like if the patient has refractory epilepsies, it kind of points towards insular epilepsies. Being on 3 medications, seizures are not under control. Undergoing resective surgery of the frontal lobe or temporal lobe, seizures are not under control. It kind of points towards that, okay, it's coming from area other than what they were focusing on, basically.
All right, very good, thank you. Well, that's all for this evening. Appreciate all of you that have attended the live session. It will be posted to the Corticare YouTube channel, and it'll also be available through a link on our website at some point. And again, look forward to the email in regards to the evaluation, and we look forward to having you again next month for another session of the Corticare educational webinar series. Thank you and good night.
Good night, everyone.